Randy Slaughter is 36 years old. He is an architect. He has health insurance through his employer. In 2024, he was admitted to Baylor Scott and White Hospital in Texas for a medical procedure. On his second day in the hospital, a billing official came to his room and asked for his credit card. Randy was on painkillers. He was groggy. He handed over the card. His final hospital bill was $33,393. His insurance covered part of it. His out-of-pocket obligation came to $9,309. The hospital arranged for him to pay $150 a month. Randy Slaughter is not uninsured. He is not irresponsible with money. He is a working professional with employer-sponsored health coverage, and he still ended up with a $9,300 debt he is paying off $150 at a time. This is not a story about one unlucky person. The system that generated Randy's bill has a name, and once you understand how it works, every hospital bill you have ever received will make a different kind of sense. Every hospital in America has a document called a chargemaster. It is essentially an internal price menu, a list of every procedure, every supply, every medication, and what the hospital charges for each one. Until 2019, hospitals were not required by law to publish their chargemaster publicly. For decades, these documents were treated as proprietary trade secrets. The chargemaster has one defining feature that separates it from every other pricing system. The prices it contains have almost no relationship to the actual cost of providing the care. Hospital markups on the chargemaster can be anywhere from 100% to over 1,000% above the actual cost of providing the service. This is documented in published legal research from Temple University Law, based on hospital billing records. The hospital sets the chargemaster price. That price determines what they bill your insurance. What your insurance pays determines your out-of-pocket share. Every number in your hospital bill traces back to a starting point the hospital set, without regulatory oversight, without competitive pressure, and for decades without any public disclosure requirement at all. Here is what that looks like in a single item. An acetaminophen tablet, generic Tylenol, costs approximately 1.5 cents per tablet. When purchased in bulk online, at a hospital, that same tablet can appear on your bill at $1.50. That is a 100 times markup on a pill that has been off patent for decades. That is not an outlier. That is the chargemaster working exactly as designed. The chargemaster exists because of a specific absence of regulation, not a specific law that created it. No legislation ever authorized hospitals to charge 1,000% markups. It emerged from a deregulated pricing environment and was never constrained. Until 2019, when the price transparency rule came into effect, hospitals had no federal obligation to disclose their chargemaster prices at all. Patients were making decisions about their care with zero price information available upfront. The rule required hospitals to post their prices online. In theory, this should have created consumer comparison shopping. In practice, it has not worked. A 2024 federal government study found that 46% of hospitals were still not compliant with the price transparency rule. The fine for non-compliance is $300 per day. For large hospital systems, paying that fine is cheaper than the competitive disadvantage of transparent pricing. The law says publish your prices. Nearly half of hospitals are not doing it, and the penalty for refusing is small enough that non-compliance is the rational business decision. Here is what most people assume when they see a large hospital bill. They assume their insurance covers most of it, and they pay whatever is left. For many people, this is true in a narrow technical sense. But the mechanics of how insurance interacts with the chargemaster create a second layer of the problem. Your insurance company negotiates a discounted rate from the hospital's chargemaster price. That discounted rate is still the starting point for your deductible calculation, your co-insurance calculation, and your out-of-pocket maximum. Randy Slaughter had a $10,000 deductible. His hospital billed $33,393. After insurance paid its portion, he owed $9,309 out of pocket. He had health insurance through an architectural firm. He was not uninsured. He was, by most definitions, adequately insured. According to KFF Health Policy polling from April 2026, about half of U.S. adults say they would not be able to pay an unexpected medical bill of $500 out of pocket. The average annual employer-sponsored family health insurance premium is $27,000 split between employer and employee, before any deductibles or copays are counted. Being insured and being protected from a catastrophic hospital bill are two different things. The chargemaster is the reason. But there is a third layer that sits above the chargemaster and above the insurance negotiated rate: the insurance company's decision of whether to cover the care at all. Cigna, one of the largest health insurers in the United States, is currently fighting a lawsuit that accuses its doctors of denying insurance claims in an average of 1.2 seconds per claim. Not 1.2 minutes, 1.2 seconds. The allegation is that claims were processed by an automated system faster than any human doctor could have actually reviewed them. This matters because denials are designed to exploit a specific behavioral pattern. Most patients who receive a denial do not appeal. The appeal process requires knowledge of medical billing codes, understanding of your specific policy, and the time and energy to navigate a system that is not designed to be navigated. The medical industry spends $83 billion annually on administrative transactions between providers and health plans. That is not money spent on care. That is money spent on billing, coding, claims, denials, appeals, and the bureaucratic infrastructure of a system whose complexity is itself part of the business model. Randy Slaughter, almost a year after his hospitalization, was on the Baylor Scott & White website when he found their financial assistance program. Going through the eligibility criteria, he found that his income appeared to qualify him for help under a medically indigent category. He applied. He sent and resent documents for 9 months. The hospital finally denied his application. When he contacted the billing department to ask about paying a lower monthly amount, the department threatened to send his account to collections. This was recorded. NBC News reviewed the recording. Randy asked to speak to the person making these decisions. He was told he could not. He asked to go into the hospital and speak to someone face to face. He was told he could not do that either. Randy Slaughter is one documented case, with recordings, records, and a named reporter covering it. He is also the experience of approximately 100 million Americans who carry medical debt, roughly 41% of all U.S. adults, according to a 2022 survey. The system did not fail Randy Slaughter. The system worked exactly as it was designed to work. Here is the part of this story that reframes everything we just covered. You are not bad at understanding healthcare bills. The bills are designed to be incomprehensible. Hospital chargemaster pricing has no standardization. Insurance explanations of benefits use billing codes that require professional training to interpret. The appeal process assumes knowledge that patients are never given. And as of 2026, nearly half of hospitals are still refusing to publish the prices that federal law requires them to disclose. The opacity is not a side effect. The opacity is the product. Opaque prices allow hospitals and insurers to bill essentially whatever they want. A system where the patient cannot compare prices, cannot understand what they were charged, and cannot effectively appeal. A denial is a system engineered to extract the maximum amount of money from the maximum number of people. You did not fail to navigate the healthcare system. You were placed in front of a system that was not designed to be navigated. So what can you actually do before you need a hospital? 1. Always request an itemized bill. Every patient has the legal right to an itemized hospital bill showing every individual charge. Most hospitals do not send itemized bills automatically. You have to ask. An itemized bill lets you identify duplicate charges, charges for services you did not receive. 2. Look up your hospital on dollarfor.org. This is a free nonprofit tool that searches hospital financial assistance databases. Many hospitals have charity care programs that are not advertised to patients. You can find yours before you receive care. 3. Ask for the cash pay rate before any non-emergency procedure. Hospitals often have a cash pay rate significantly lower than the chargemaster price and sometimes lower than the insurance negotiated rate. You have to ask specifically for this. It is not offered. 4. If your claim is denied, appeal. The first appeal is free and requires only a written letter. Most people never send it. Everything we covered today, the chargemaster, the insurance layer, the denial system, this is one hospital visit. We have not touched prescription drug pricing. which operates under an entirely separate and arguably more complex system. That is next week. Subscribe so you do not miss it. And if you know someone who has ever been confused by a medical bill, which is most people, share this video with them. That is the most useful thing you can do with this information.